Good afternoon, and I'm happy that a few people are here to listen to heart failure, the present and the future. How many of you are in the medical field? Great. But I'm going to explain what heart failure is, just to kind of get us started. And as you all know, the heart is a pump. So when it starts failing as a pump, one gets shortness of breath, fluid accumulation, you see edema bilaterally, and then there's also exercise limitation. So heart failure is a syndrome, and the cause of that is the heart function, which is impaired. So it's a problem that is very prevalent and increases the prognosis, makes it really difficult for patients to have a quality of life. And when you have advanced heart failure, which is the end stage where a patient, in spite of all the good therapies, medical therapies that we have, the patient, unfortunately, cannot take those medicines appropriately, has blood pressure problems, keeps coming back into the hospital, as you already heard. And that type of patient has exhausted all other options. So what are the options that we can offer them? If appropriate, we can do heart transplant or provide mechanical circulatory support devices, something that you take off the shelf and make the heart pump better. So I'm going to talk a little bit about heart transplant and then go on to talk about the left ventricular assist devices, the heart's pumping chambers at the bottom. There's a left side and the right side. So we support the left side most of the time. If both ventricles or pumping chambers are affected, you can put in a total artificial heart. So there's a lot of research ongoing to find out, and you already heard the young people from the AHA who are doing stellar research to get us to where we are today. And unfortunately, heart transplant is limited by donor availability. And we are fortunate that in the year 2022, we've come far in terms of mechanical circulatory support devices to help the failing heart. So we just started a heart transplant program at Christ Hospital, and we're looking forward to offering the community an additional option when you approach end-stage heart failure. So this graph just shows that the growth of transplantation. I don't know if you have a pointer here, but if you look, it's from the 1980s to 2015. And at the beginning, the surgery was a success, but there was no medication that kept these hearts going. So there was a very slow uptake until cyclosporin, which was a calcineurin inhibitor, an immunosuppressive agent, was used. And then you can see a big rise in the number of transplants. And then everybody was being put on the list because there's a lot of people that need hearts. And you can see that there was a plateau. And then in the last few years, it's been going up a little bit, but still donor limitation is a problem. So why do we still do transplants? It's been 50 years, more than 50 years since we did the first heart transplant in South Africa. Christian Bernard did it. And since then, there's been incredible advances. We have new immunosuppressive therapies, more protection for the heart on bypass, a lot of new drugs, new therapies. And the patients also have gone more critical. They have more problems coming into heart transplant. But yet, we're able to do excellent survivals. So patients are expected to live, about 90% of them live the first year, and at the end of 10 years, it's about almost 13 years. So the median survival is 13 years, and I've seen a number of patients who now walk in and out of my clinic who are 25 years and 30 years out of transplant. So it's a very viable option for end-stage heart failure, but limited by donor availability. This is something new that I just wanted to show because technology is improving what we can offer our patients. Research is very important. This is a perfusion system. It's called the organ care system, and it perfuses the heart outside the donor and keeps it going for many, many hours, perhaps as long as 24 hours. And that's because you can perfuse the heart with solution, check the coronary perfusion pressures, and also look at the parameters, metabolic parameters, use different solutions. So this is coming. I mean, it's just been starting to use, and you can see on the right side, a physician is showing the recipient that you're going to get this heart. So that's very, I think, technology has advanced very significantly in this area. But we now look at lots of mechanical circulatory support devices because you can take it off a shelf and do the surgery. And so there's been a lot of advances in this field. We first started with pulsatile pumps, which are just like the heart. Squeezes, relaxes, squeezes, relaxes. So pulsatile pumps were the first in the chapter 1 of where we were with circulatory support. And of course, these were not very durable. I remember the time when patients, after a year or two, these things stopped working. And they were large, they were noisy, and we needed better pumps. And this was the first one that got approved, and there was only a 28% survival at 1 year, but it was much better than the medicines that those end-stage heart failure patients were getting. So if you look at A, that's where the connection is made to the bottom of the left ventricle, which is the apex, and B is where it goes to the aorta. So it's kind of a detour of the left ventricle. And it provided pretty good quality of life for the time that they were alive, but it wasn't perfect. But again, that's what innovation is all about. It starts with a good idea, and you keep doing research, you keep doing things to make it better. So chapter 2 was where we looked at continuous flow devices. These were the previous devices had to have valves, which didn't last very long. The continuous flow devices did not have valves, and they had minimal pulsatility, and were there for many years. We were able to prolong the mechanical lifespan of these pumps for almost 10 years and longer. And so these were smaller, these were silent. I remember the time when you could hear the patient with the first generation pumps, where if they were even outside the door, you could hear the sounds. And these became small. It's like it's how miniaturized the devices become as time goes along, and that's where technology is very helpful. Of course, these pumps have energy requirements, which are fairly significant. And this was the second generation called the HeartMate 2. And it was like a rotator type of device. There was an inflow from the apex or the left ventricle and to the aorta. And this was very good. I mean, it gave us much better survival, much better quality of life, and was used in a fairly large number of patients. But there were still problems because we had clotting, we had blood cells that were not quite the way they should be. So there was hemolysis, which is breaking up of those blood cells and causing strokes. So we extended life, but there were problems. So then this is the third generation, which is now approved, as there are indications for pumps will be, one is as bridge to transplant, because people who are waiting for donor hearts wait for very prolonged periods of time, and they can't afford to wait. You die waiting for a heart. So these pumps keep people alive and to get the next stage. So it's called bridge to transplantation. But then we figured out that you could use these pumps as the end of everything, that you could just give somebody who's not a transplant candidate or an older person who gets excluded from getting a transplant, and that's called destination therapy. So this pump is now approved for both bridge to transplant and destination therapy, and is much smaller, put right into the pericardium, so it's right smack into the heart. And there is very minimal thrombosis. Thrombosis is blood clotting. So it's manufactured in such a way that the technology has improved extremely well to make survival better, quality of life important, very good, and decrease the adverse events. So just kind of to show you what these left ventricular assist devices called LVADs look like. The one on the left side shows you the device at the apex, and it's connected to the aorta, which is the major vessel that comes off the ventricle. And you can see that there's a controller and battery packs, so you walk around with the battery packs. And at night, you can plug into the console. And what's called the drive line, the connection between the pump, which is inside, and the controller, unfortunately, is outside. So one of the side effects is there's infection, higher risk of infection. So this push has been, the goal has been to end up with everything implantable. If you could put everything inside, then life would be good. But unfortunately, that technology is still not there. We have done some research and had some experience with total artificial hearts that we implanted completely into the person. But these were huge. Battery packs were, TET coils were used, but still they needed charging. There was a lot of other problems. So this still has this drive line that comes out of the skin, and the pump itself is maglev technology, which is magnetic levitation, centrifugal force, and you have the same type of connections for all those pumps, but this works very well, has not had probably minimal thrombosis and very few strokes. You still have infection, but it's one of the best pumps that we've had so far. But that's not enough. We're still not satisfied because we want things to improve. And that's where research is so important, because we're always looking to do the next step. This is good, but let's get better. So the present is, of course, we have this, and I didn't talk much about the total artificial heart. When the left ventricle and the right ventricle don't pump, then you put in the total artificial heart. And we've had improved outcomes with just the left ventricular assist device. So 83%, if you look at survival, it's getting as good as heart transplant. So that's compared to that first generation, which I showed, which is large and clunky. That's about 20%, and we've improved the survival by new pumps. So if you're looking, what's our dream? What's our goal here? We want something that's durable for prolonged periods of time, so much greater than 10 years. And unfortunately, these are set. The speed is set, and when you exercise, you need more blood. And these pumps are still not very physiologic and don't improve your exercise capacity to the extent that we would like to see. And we want low energy requirements, because that's the only way we can implant everything and keep it inside the body and not require charging all the time. And it has to be totally implantable. So that's the future, and we are working at Christ to have some new devices, both artificial hearts as well as left ventricular assist devices that now are in the animal model, but in the future will become a reality if everything goes well. So in summary, the current left ventricular assist devices have improved survival to the same extent as heart transplant. But again, they're the latecomers, because we've had transplants for 50 years, so everybody knows transplant. We know it to do it well. And we have it's very good survival, very good. You don't have to carry a battery pack. You don't have to do all that. But you have to take immunosuppression. There's always the downside. So, but it's really something that, unfortunately, having been in the transplant field for many years, I would wish that we could give it to a lot of people, but donor limited still. We've extended our donor criteria, accepted high-risk donors, but still there's not enough. So these devices are going to be a big part of the future for the end-stage heart failure patients. And we want them implantable, we want them durable, and totally implantable devices are coming. We're involved very heavily with that research. And we are going to wait and not to have major sternotomy, but ways to put small devices in so that these devices can work through a thoracotomy or something that's less invasive than a sternotomy. So I'm going to stop there because this is a field in evolution, and I was very pleased that I could speak, even if it's a small audience. And I'd answer a few questions if any of you have questions.